A very good evening, ladies and gentlemen. This is Dr. Harsh Chaturvedi, Associate Vice President of Pulse Pharmaceuticals. I represent medical affairs and clinical research, and taking you this program on a very important topic of role of nutrition in neurocritical care. Neurocritical care and nutrition, we have been talking about it, but we have not probably been able to understand very clearly that how the nutrition impacts and where does it come in today's management, the disease management. We know diet is increasingly understood to impact various neurological functions, and various animal studies have shown that the consumption of Western diets, which are especially high in saturated fats, refined sugar, and processed foods, impairs learning and memory and is associated with oxidative stress, inflammation, and also mitochondrial dysfunction. On the other hand, we know that various aspects of diets, for example, polyphenols and dietary patterns, especially when we talk about Mediterranean diet, they have antioxidants, they have anti-inflammatory properties. So when we talk about neurological conditions such as epilepsy and multiple sclerosis and traumatic brain injury, where these are though they are distinct disease processes, but each exhibit increased oxidative stress and neuroinflammation, also a disruptive energy metabolism, and thereby reducing this pathology has the potential to improve the neuronal function and ensure the repair and the growth. In light of these very small understandings of ours and the pathophysiological factors which are influenced by the dietary means, it is quite reasonable that the diet could alter the course and the outcome of these neurological conditions. To get a hang of it, so to say, and to understand better, we have with us a panel of experts today who will be sharing their thoughts and experiences on the role of nutrition in the neurocritical care. Um, we are joined by today Dr. Praveen KS, who is head of Department of Neurosurgery in Crestwell Hospital. He'll be talking about the role of nutrition and neurocritical care. And we also have Ms. Srimati Venkatraman with us, who is the consultant clinical dietitian with Trustwell Hospital. She'll be sharing her thoughts with us on nutrition management and practical approach to neurocritical care. But before I invite Dr. Praveen and Ms. Srimati to speak on this, uh, I would briefly take this opportunity to present my organization, which is Pulse Pharmaceuticals, uh, because I'm not sure how many of us uh, know about it. It's just a brief presentation. Um, as you can see here, the Pulse it stands for Passion for Innovation and Compassion for People. And as I mentioned earlier during my opening statement and welcome, that there's a IAPEN in association with Pulse Nutrition Institute, which invites you to this national webinar on the role of nutrition in neurocritical care. To talk about Pulse Pharmaceuticals, we are a patient-centric, innovation-driven integrated pharmaceutical company, which has been in existence for past 25 years. We have pan-India operations with presence in seven marketing divisions. We are present in the international market. Also, we operate in over 40 countries across the globe. We have world-class infrastructure, three R&D setups, and three manufacturing units spread over the state of Uttarakhand and Telangana. And we are pioneers in research in nanopharmaceuticals, medical nutrition, and now we are also involved in CAR T therapies or stem cell, as you would like to call it. This is a very brief introduction of Pulse Pharmaceuticals. When we talk about Zenova or Pulse Nutri-Sciences, as the division has been rechristened as, we have a range of brands which go under the brand name of Copville, Canville, and Gradual. They take care of diabetic nutrition, cancer nutrition, renal care, dialysis, liver care, and critical nutrition and weight management as well. So this is a very brief thing that I've used to talk about my company, sorry. And moving on, uh, I'll introduce our first speaker for the day. The first speaker is Dr. Praveen KS, and as I mentioned, he'll be deliberating on the role of nutrition and neurocritical care. Dr. Praveen, though, doesn't need any introduction to this audience, but it's customary, so I'll read out a few lines for Dr. Praveen. He is head of Department of Neurosurgery at Crestwell Hospitals, Bangalore, and Sri Shankara Cancer Hospital and Research Center. He is a MCH in neurosurgery with fellowships in spinal surgery from Germany. He has numerous presentations at national and international forums and is a life member of Bangalore Neurological Society, Neurological Society of India, and the Association of Spine Surgeons of India. With these words, I invite Dr. Praveen KS to share his thoughts on the role of nutrition in neurocritical care. It is over to you, Dr. Praveen.
Thanks a lot, Harsh, for the kind words. I'm really honored to be on this panel and then to share my few thoughts on this particular upcoming topic. This is a very recently, this topic is now a hot topic. And in fact, one of my colleagues asked, how come you being a neurosurgeon, now you're going into nutrition? I said, see, nutrition is very important to take care of not just ourselves, but also our patients. I'm a foodie, so I told him that wherever there is food, I'm going to be there. So, and then he had a good laugh about it. But jokes apart, nutrition is very important in the overall management of any patient of any specialty, more so in neurocritical care. And the importance of this is only now being recognized all over the world. So today, let me just take you through a few of my thoughts. See, it's a very vast topic. I'm not going to spend too much time on any one particular diagnosis or condition. I will just roughly tell you where all nutrition will affect neurology and how the neurology will affect the way that we deliver nutrition. So each one is interdependent, and there are certain common areas where we will need to just spend a few of our thoughts in trying to adjust not only the content of our nutrition, but also the way that we administer it to our patients. Because most neurological patients have special needs. Apart from nutritional needs, they also have special needs towards the administration of nutrition also. So all of us understand that nutrition and its deprivation can lead to long-lasting changes as far as neurology is concerned. There are a lot of neurological disorders which are caused by nutritional problems, like say vitamin B12 deficiency, leading to subacute combined degeneration of the spine, or to a simple peripheral neuropathy, diabetes leading to peripheral neuropathy. But there is also specific neurological conditions which also hamper nutrition. For example, a patient, say with myasthenia gravis, not only will he have difficulty in imbibing food, but also in assimilating that food, and also may have risks of aspiration. So there are diseases like say Alzheimer's, which does not allow the patient to even ask for food. There could be neurological conditions with obtundation of mentation, leading to say hyponatremia or other calorie malnutrition, leading to adverse effect in those patients and not allowing them to recover optimally. We have also, a lot of studies have been done in these neurological patients, and they found that the dysphagia is a very prominent part of neurological presentation in stroke, and almost about 60-70% of them with stroke have some difficulty in swallowing, requiring either temporary parenteral or forms of non-conventional treatments, nutritional administration, but also some of them, about 15-20% of them, requiring a permanent diversion of nutrition through other means. And about 50% of the elderly with neurological conditions may also end up having dysphagia. So the neurological patients also having malnutrition, especially in the critical care setup, has been found as high as 1 in 3 patients admitted to the neuro ICU are likely to have malnutrition. The assessment of such patients as to the extent of nutritional disability and the kind of nutritional disability also poses a lot of problems, mainly because the patient is not able to get up, stand erect, where your standard anthropometry measurements do not apply to these patients. It's very difficult to say weigh the patient. It's very difficult to assess the height of the patient, and it's very difficult even to ask the patient to let them know their weight. So most of these people may be aphasic, may not be able to talk, may not be mobile, and they are also unable to attain an erect posture, say for weight management. So other methods have been devised, like for example, skin fold thickness for assessing sarcopenia or muscle wasting. Sometimes muscle wasting may be because of the primary neurological disease, like say in motor neuron disease or Guillain-Barré syndrome, where the nutritional contribution to sarcopenia or the muscle wasting may be very difficult to specifically assess. So hence, special methods will need to be devised for assessing nutritional problems in these special set of patients, and hence every patient in the neurocritical care has special needs. Of course, this leads to increased morbidity, mortality, increase in ICU costs, increase in the overall mortality, leading to adverse outcomes. And these patients have been shown to have better outcomes once the nutritional management has been optimized. And that is the crux of the next talk. I think Dr. Srimati is going to enlighten us as to how we could make a change in these patients and reduce the incidence of morbidity as well as mortality in these special set of patients. The overall, there's a complex algorithm put up on this slide. It may be a little difficult for you to understand the entire flow of this, but central to the theme of this particular algorithm or the flow chart is that there is increased catabolism, and also with limited availability of calories and micronutrients to these patients with neurological disorders, ultimately leading to delayed recovery through various methods of increased oxidative stress, as well as to reduced nitrogen fixation and reduced catabolism, anabolism. So this will lead to most of these patients, if you see even beyond 5 days of stay in the ICU, many of them will land up with severe muscle wasting unless special care is taken in order to maintain the nutrition as well as to maintain the mobility. So sarcopenia is the commonest manifestation of malnutrition in neurological patients in an ICU setting. Of course, this can lead to respiratory failure because of loss of muscle mass. Also, as I said, the patients with respiratory failure, say in Guillain-Barré syndrome or in myasthenia gravis, or patients with other restrictive disease or a spinal cord injury, for example, following a trauma. So these patients already have respiratory failure and difficulty in mobility and also imbibition of food. Such patients are given to advanced effects of these nutritional disabilities. Then critical illness polyneuropathy is a specially recognized entity which is more recognized these days, but the primary treatment of which is one, nutritional replacement, as well as treatment of the primary cause. This has been increasingly recognized these days because of the use of, say, one, the clinicians' awareness, as also the use of, say, nerve conduction studies, which will detect that the multiple neurons, multiple nerves are affected, leading to severe wasting and distal diffuse weakness without a specific cause within the central neuraxis. This will lead to low immunity, further compounding the effect of neurological disorders on these hapless set of patients, leading to increased risk of ICU infections, ventilator-associated pneumonias, and also bed sores, preventing them from mobilizing further, and also leading to further vicious cycle of infection, leading to catabolism, leading to more infection. These patients also have cognitive disability secondary to these nutritional disorders, like, for example, in a hyponatremic patient, they will have obtended mentation, as well as they could go into coma if the sodium is either undercorrected or overcorrected within a very short period of time. These will also lead to muscle mass loss as well as locomotive disabilities. So, in fact, I could go as far as saying that nutrition affects the nerves not only after we are born, but also even before we are born. Many of these disorders can lead to neurological diseases, which could be related to, say, DNA defects secondary to impaired maternal nutrition. This is a separate topic. I will not be touching upon this today. These pictures, as I've shown in this particular slide, are very, very commonplace in any neuro ICU setup. Here you see an elderly patient with a craniotomy scar on the left side of the brain. That's very, very clearly seen there, with severe wasting You can see that extent of wasting in the lower limbs, extent of temporal hollowing, extent of hollowing within the cheeks, and the prominence of the neck muscles. You can also see on the same picture, one of the pictures, that there is severe wasting of the small muscles of the hand and the tendons are visible. On the second picture, you can see that the dorsum of the hand is swollen, as is also the forearm, because of the effect of hypoalbuminemia. And the patient is already on a PEG tube, which is a percutaneous endoscopic gastrostomy tube placement within the stomach. And this is also commonplace in many of these patients. This patient is already on a tracheostomy and a PEG tube, and probably already has decubitus ulcers. And this is just a complete vicious cycle just waiting to happen. I divide these neurological lesions and the relationship with nutrition into 4 stages, rather than 4 stages of deglutition or imbibition of food, that we can call it. And then I will try to list out the disorders which can lead to problems in each of the stages that we use to obtain food and to ingest and to digest them. So the first stage, as I say, the first phase is when a patient asks for food. So for asking for food, a person has to be able to communicate, has to know that he has appetite, has that he has either he's hungry or he's full. His satiety centers have to be working normally. He should be in a position to understand that there's something called as hunger within himself. He should be able to respond to what are called as endogenous stimuli. So most of these neurological patients in a critical care setting are in altered sensorium, are unconscious. They may not be able to differentiate between the quality of food, thereby affecting the overall. So hence, attention will need to be given to this particular phase of nutrition in the first place. The second stage of nutrition that we obtain can be divided as when a person is able to mix the food or go get the food by himself and is able to feed himself. That means feed the food through using his hands into his mouth. So this will involve a set of motor functions, set of coordinated motor functions, and also that the patient is in upright position, so he's able to put the food in his mouth and then chew. There are certain neurological disorders which affect this phase of obtaining nutrition. I'll just list out in a few minutes. The third phase of obtaining nutrition will involve, after the food has gone into the mouth, we need to chew the food and we need to swallow the food. This will involve that the patient has good dentition, has good tongue function, has normal salivation, is able to chew the food properly and grind the food between the molars, and also that all the stages of deglutition or swallowing are intact. The fourth phase is that, of course, after the food has passed through the esophagus into the stomach, the patient should be able to digest and imbibe the food properly, which will involve micronutrients, the water metabolism, as well as other micronutrient metabolism. So the first phase, as I said, many of these disorders, say a patient with head injury or a patient with, say, stroke, most of these patients are likely to be unconscious and they're unable to ask for food. Many of the times, these patients may have multiple issues, including paralytic ileus or injury to the abdomen, delaying the probability of feeding the patient immediately also. The patient will not ask for food. The patient will not say that he's hungry, like say in stroke or even a tumor patient with an extensive glioblastoma leading to loss of the left-sided dominant lobe tumors can lead to these kind of cognitive lesions, impairing the patient's consciousness in order to seek food. Patient who has dementia like Alzheimer's or a global dementia can also have similar such picture where he's unable to ask for food. Here, there are certain other tumors, say in the hypothalamus, which lead to damage to the satiety centers. I've had a small 3-year-old child who I operated for a hypothalamic tumor, a grade 2 tumor. And the mother would say that in the immediate post-op period after the patient was discharged and then gone home, a 3-year-old child would easily finish off 4 packets of biscuits and about a couple of slices of bread easily overnight. And the child put on so much weight, and then we told them that it is probably because of the effect of the hypothalamic satiety centers. Luckily for me, that settled over a period of time, both with interventions by the nutritionist, as well as that the hypothalamus also recovered completely. Now the child is doing well. So it is important to recognize that the cause of either overnutrition or undernutrition may actually be the brain and may not be the kitchen or the dietitian who is serving food in a particular hospital setting. Of course, a patient may also have a depressed effect leading to, say, either anorexia or bulimia, where it could lead to either overeating or undereating. And this will need to be recognized if we have to make proper nutritional interventions. So that this is where a nutritionist who is able to understand the patient's requirements, right from the ability to ask for food, as simple as this particular step of getting nutrition. So once the nutritionist understands this particular thing, and there she has a victory, or she or he has a victory, and then the patient can already be on the road to recovery. So the second phase of nutrition, as I said, is the ability to feed oneself. Many of us take this particular thing for granted. In fact, many of us, given the chance, I think if we find any particular webinar boring, we have the luxury of not being able to be on the screen visible for all of us to see. We could easily reach out for a pack of chips or anything else, and then we could eat. But many of our neurological patients may not have that luxury. They either have severe gait disorders, they're not able to walk to the canteen, walk even to the vending machine, or walk to the kitchen and then feed themselves. Either they have severe tremors, or they have weakness of the hands or legs, leading to inability to even walk to the place where food is kept. They also have coordination disorders, sometimes with the frontal lobe lesions, like in either head injury or in particular Parkinson's, where they have extreme amount of tremors and stiffness, leading to difficulty in feeding oneself. Many of these patients may mask all this by refusing food and thereby getting under the vicious cycle of malnutrition. Most of these people, in order to avoid social embarrassment, may just refuse to take food in a public setting. If you see an elderly patient in a hall full of delicious buffet, standing alone and refusing to eat food, you know that there is some problem there. Either it's the patient is unaware that there's tasty food around, or he's embarrassed about his tremors, or he's weak or incoordinated enough to go and get food and feed himself. He doesn't want to make a fool of himself, so he just refuses. He says, no, I'm full, I don't want to eat. Again, this phase is also very, very important to notice. Say, even especially in the critical ICU, critical care setting in the ICU, most of our patients will not have access to food, and it is imperative that a nutritionist or a dietitian recognizes these things and provides timely food and also method of administration of this, so that the patient's nutrition can be maintained. Coming to the third phase of getting nutrition, as I said, is the ability to chew the food and then swallow. Most of us, again, many of us depend upon our automatic swallowing ability. The moment there is food in our mouth, we automatically chew and we swallow, and all the phases of deglutition or the swallowing are followed in a serial manner. This is an extremely complicated and a well-coordinated series of events which happen in the back of the throat and the upper esophagus. We just take it for granted. The brain has so much function to do in order to prevent the food from going into the wrong pipe. There are two pipes there sitting in the back of the throat, which is the windpipe and the food pipe. And very easily, if the patient is not conscious, or if the patient has a problem in swallowing, or if the food is given by the wrong route, like if the patient is unconscious and then you feed food through the mouth, the food is invariably going to land up in the wrong pipe, and then it's not going to reach the stomach. Instead, it may end up causing a lot of harm. So a patient with, say, a trigeminal neuralgia or severe head injury may not be able to chew the food. He may have a mandible fracture. He may have loose dentition. So hence, say here a nutritionist role is to provide, say, a liquid food through a straw. So in order to improve the quality of the food, they can devise methods to improve, say, supplements within the food that they provide. But they should understand that this patient has a special need, and it is in the third phase of getting nutrition, and then we need to pay attention to this particular phase of nutrition. A patient with low cranial nerve palsies, like, say, in a head injury or a CP angle tumor, which is operated, a posterior fossa tumor operated, these patients will have a risk of severe aspiration if attention is not given to this. Most of these people, if for a temporary period, they may be on a Ryle's tube or a nasogastric tube feeding, or they may go on to PEG tube feeding on the long-term basis. Some strokes do also cause central swallowing disorders, like, for example, a left-sided Broca's area stroke, an MCA territory stroke on the left side, will lead to incoordinated movements of the posterior part of the pharynx, leading to difficulty in swallowing. Of course, there are non-neurological surgeries, like, say, a thyroid surgery leading to recurrent angina palsy, or a carcinoma lung with involvement of the recurrent angina nerve can also lead to difficulty in swallowing and risk of aspiration. The last phase of getting nutrition is after the food has passed the posterior pharynx and gotten into the esophagus, it needs to enter into the stomach, go through the small intestine, the large intestine, and then it has to come out. There are a lot of steps involved in not only the food getting mixed with the adequate and appropriate digestive juices in its own hollow viscous, but also from micronutrients getting absorbed. Most of the patients, say, for example, a patient with pernicious anemia or a vitamin B12 deficiency with atrophic gastritis, they don't have the secretion of intrinsic factor, and hence the natural vitamin B12 which is present within food may not be absorbed properly. And this will lead to, again, neurological disorders, as I've already mentioned earlier. Water is a very, very important part of our nutrition, and either too less or too much can produce equally devastating neurological disorders. Hence, the nutritionists, the moment they come into the ICU, they look at if there are any water restrictions, like, for example, if the patient has had SIADH, that is the syndrome of inappropriate secretion of the antidiuretic hormone. In such patients with already low sodium, we have to make sure that there is water restriction. But the moment the water or the liquids are restricted, we also have to make sure that the adequate amount of calories are administered to this particular patient. Hence, the very, very important role of the nutritionist here to make sure that the volume of total intake of fluids is generally kept below 1.5 liters for that particular patient for 24 hours, but without compromising the calorie content. Too much water, again, can lead to low sodium, as I said, or too less water, like, for example, a patient has undergone, say, pituitary surgery, or a patient has undergone a craniopharyngioma surgery or hypothalamic surgery. So those patients have what is called as a hypernatremia and diabetes insipidus, where there is excess accumulation of sodium within the bloodstream and the patient passes a lot of dilute urine. So here, if we don't replace adequate amount of water or other liquids, the patient can get severely dehydrated, leading to a lot of side effects. As I said, sodium is one of the commonest dietary modification, and then an intelligent nutritionist or a dietitian can make a real difference in maintaining this particular thing. I was also, in fact, the increasing of, say, dietary salt intake, as along with other supplements like sodamine tablets or other medical measures to improve the sodium, form a very, very important part of treatment of hyponatremia. As I said, achalasia or Hirschsprung's disease or paralytic ileus because of immobility and spinal cord injuries can lead to difficulty in imbibition of the food which is already gone in. Most of those patients will be on parenteral nutrition, so hence importance has to be given to this total parenteral nutrition in these kind of neurocritical care settings. There could also be the setting of severe metastatic cancers leading to severe catabolic states. Hence, the nutritional requirements of these patients in the ICU goes up. Or a patient could be obese because of various other issues, but the importance of noting this obesity is that there could be an underlying sarcopenia or muscle disorder leading to respiratory failures and other things. So, importance of measurements of these particular parameters are necessary to prevent adverse effects. Now, okay, we have gone through these 4 phases. We know that there is a critical care patient in the ICU, and most of these we have divided them into one of these phases. Many of the conditions can produce defects in any of these 4 phases of getting nutrition. And we may have to address sometimes all the 4 phases of nutrition, or maybe more than one, or maybe just one of the phases of this nutrition I've just mentioned. What do we do now? First, the first thing to do is, of course, apart from maintaining normal nutrition, we need to be aware of certain assessment factors where we assess how poorly the patient's nutrition is. And hence, there are a lot of these questionnaires available online, and I will not go into the details of these. These come under the purview of neuronutritionist or a dietitian who is dedicated to the care of such critical care settings. A lot of these questionnaires are readily printable, and then they can be used on a regular basis. The nurses can be trained to fill up these questionnaires, and an easy compilation can be done and on a day-to-day basis, and then appropriate measures can be taken by the attending dietitian. There are a lot of biochemical and metabolic parameter assessment which is done. In fact, in our hospital, Dr. Srimati routinely asks for certain parameters which are used in our neuro patients who have nutritional disabilities. And then that will generally include a liver function test, an albumin measurement, serum calcium measurement, serum magnesium and potassium, and other biochemical parameters as required. If a patient has low BMI or an excessive BMI, that has to be documented. And as I said, all these parameters will need to be documented on a regular basis in the ICU chart, and appropriate interventions will need to be done. Any patient requiring nil oral status to be maintained either because of their surgery or because of some other associated comorbidity for more than 5 days will need to be, say, fed through a total parenteral nutrition. During such times, you have to make sure that the patient does not go into sepsis or hyponatremia or one of those side effects of TPNs. So screening has to be done, and specific questions can be used to assess and classify the patients in the respective compartments. And this is not an absolute compartment, and then the patient could be easily moved from one compartment to the other on a daily basis. Hence the importance of continuous assessment ongoing. Specially trained dietitian in neurocritical care can really make a difference to these patients. And in turn, this dietitian can train the nurses in the ICU to document the required parameters. What does it involve to improve the nutrition of these kind of patients? The first thing to assess, as I said, about 60 to 70% of the patients with stroke can have impaired swallowing or impaired dysphagia. I mean, have a dysphagia in the beginning phase. Most of those patients settle down. About 15-20% of them may be left with a permanent dysphagia, either because of impaired stages of deglutition or because of a recurrent laryngeal nerve involvement or low cranial nerve involvement. And hence, this has to be taken care. Of course, we do a swallowing assessment. A physician intensivist is involved in assessing these particular functions. An ENT surgeon can help in assessing the amount of swallowing involved. And these multi-speciality setup will be required in order to assess the proper swallowing function. This is one of the videos of one of our patients where you can see clearly an aspiration of liquid through the epiglottis into the vocal cord. A trickle of fluid can be seen going into the larynx. So hence these things are very, very important to notice, and then this can be averted by other methods of feeding. And then the commonest and the most important thing is to go into a nutritional supplementation for these patients. I will not go into the details of these particular steps. Of course, a multi-speciality setup with multiple people involved can make a difference for these patients in terms of counseling. They'll require extensive family counseling, not only treatment in the ICU, in the ward, treatment at home also requires special care to be done. So education of the family plays a very, very important role. Of course, there are a lot of support groups available for these things, and these can be utilized. Dr. Srimati is going to touch upon the nutrition supplementation. So special routes of administration like the nasogastric tube or the PET tube may have to be commonly used. So coming to the end of my talk, as I said, these are the commonest things that I can pick up from my talk. There are very, very prevalent nutritional disorders in these neurological patients in the ICU setup also. Early recognition will lead to better outcomes, definitely. And early enteral feeding, as everybody knows, is always beneficial. And specialist setup is important if you have to make a difference to these set of patients in terms of having a neuronutritionist. Speech language therapist essential for dysphagia treatment. So creating awareness amongst caregiver is the need of the hour. Thank you.
Thank you so much, Dr. Praveen, for emphasizing on especially the need for early recognition of malnutrition in the patients. We'll be taking a few questions after we have had the talk of Dr. Srimati as well. And so I take time now to invite Dr. Srimati to make her presentation. We know Dr. Srimati Venkatraman is a visiting consultant and clinical dietitian in Trustwell Hospitals and Dr. Digest Clinic. She is a MSc DND and a certified diabetes educator. She has certifications in community nutrition and sustainability development, bariatric nutrition, and critical care nutrition. She is the founder of Mitha Ahar, Eat to Live, a nutritional counseling platform, author of Nutrition and Biochemistry for Nurses, which has published by Reed Elsevier. She has published numerous articles in press and online, and is a member of ESPEN, an European Society and European Society of Swallowing Disorders, IDA, and NSI. With these words, I invite Dr. Srimati Venkatraman to make her presentation on nutrition management and practical approaches in neurocritical care. Ladies and gentlemen, we'll be taking the questions after Dr. Srimati's presentation from both Dr. Praveen as well as with Dr. Srimati joining us in that. It is over to you, madam.
Thank you so much for the introduction, Doctor. Good afternoon, everyone. I would like to thank Pulse Neuroscience for inviting me to deliver this talk on nutrition and the neurocritical care, practical aspects, and always a privilege to share the dais with Dr. Praveen in Trustwell Hospitals, where he gives a lot of importance for nutrition in the neurocritical care. Thank you, Dr. Praveen, for accepting the invite and doing this today with me. So let's go in, and I'm glad to see so many very familiar names in the audience, and we will take up the questions later, as Doctor said. So hope you could see my screen in the full mode. So today the objectives will be the most.
You need to go to the full screen mode.
Sure. Okay.
Yeah.
Okay. So the objectives would be the most current recommendations for providing nutrition to the neurocritical care population. Because as we all know, the data is very much sparse, but I'm going to take on what are the the last 5 years papers. So the main objectives here in a neurocritical care nutrition would be to assess, detect, prevent and treat malnutrition. Initiation of feeding at the right time is important. To avoid inappropriate feeding, let's do no harm is the first thing. And enteral nutrition. Is parenteral nutrition necessary in some neuro cases? Monitoring is very vital, and special considerations in the neuro ICU. So now what happens is the site of insult. The site of insult can be in the form of surgery, it can be a trauma, it can be a critical illness, which shows a lot of metabolic and hormonal changes, which is basically termed as stress response. When I started doing for neurocritical care, many people commented that it is so easy because the gut is anyway working, all you have to do is feed. But when you get into all the nitty-gritties, it is very important that how much of catabolism happens and the right nutrition is very important. So the stress response to an insult evolves with each phase. As you all know, a lot of dietitians in the audience which are practicing critical care nutritionists. So there is an ebb phase and a flow phase. The ebb phase is less than 12 hours. But now recently what they have done is there is an acute, chronic and a recovery phase. So what happens is in that the patient undergoes in an ICU resuscitation. So the initial management to maintain adequate supply of glucose to the vital organism via the catabolism. So the body, the brain, as you all know, needs a continuous supply of glucose. So the body always, when there is an insult in the form of a stress response, it is going to ensure that there is catabolism, any form it will try to find out, so that there is an adequate supply of glucose to all the vital organs. So even if it is via catabolism of the stored body fuel. So there is an acute phase, there is a chronic phase, and there is a recovery phase, though there is a gray zone between when it goes from acute to chronic to recovery phase. Especially what happens is when you know that there is an early acute phase, when you see that there is a biphasic metabolic response, and you can see that time is the essence here. There are pro-inflammatory agents that are acting because of the catabolism. So the changes associated with this stress response, it affects all the organ systems of the body. And there is, in the early acute phase, which is that reduced non-protein calories and protein supplementation up to 1.5 grams to 2 grams per day is essential. And in the early sepsis and the critical care, where it has been shown that there is decreased energy is spent as the disease severity goes up, and there is a pro-inflammatory process that is going on. But what happens subsequently in neurocritical care is this goes on to keep on increasing exponentially. So when there is a chronic or recovery phase of critical illness, there is the energy expenditure, and the catabolism is also very high, and the supply demand is also very high. But the problem is we need to identify when we have to first screen. Rapid and simple validated tool. Dr. Praveen has told about the SNAC and the MUST. I will talk about different tools also. We need a simple validated tool which can be done as the patient would be bedridden, and also we need to screen, identify at-risk patients so that we start the nutrition care process in a very timely manner and not lose time. So what is malnutrition? So in 2012, the IAPEN has defined malnutrition where there is starvation-related malnutrition, but there is no inflammation, the chronic disease is there, and also you can, as you all know, that we use different tools to make sure that there is what is at risk. Usually it is decreased energy intake, weight loss, loss of muscle mass, GI intolerance, loss of subcutaneous fat. In neuro, we also talk about mobility. We also talk about GI motility because constipation is very, very common in these bedridden patients, and they lose lean body mass very, very fast. Now, in nutrition delivery, what is this in acute critical illness? When there is a prolonged acute critical illness and there is a chronic critical illness. Now, what happens is we need to make sure that the nutrition support protocols in respective hospitals is in place, because it has been shown that having very good protocols with the nutrition support team and the multidisciplinary team has shown clear benefits in neuro ICU. You all know in all ICUs, we need to have proper nutrition support teams with protocols, which is very tailored to the particular hospital. So as long as a neuro patient is concerned, it's not only like a liver or a kidney where after critical care, they just go to the ward and they are fine. What happens is many cases, there is a prolonged rehabilitation phase. So the critical illness phase is very prolonged. And if you don't give the timely early enteral nutrition, or whether they are eating orally, the oral nutrition supplements, there is a lot of muscle wasting and the adverse effects keep on increasing. And this is how they have a long-term muscle wasting, losing lean body mass, and the more the deficit, it keeps on adding up, and this is not going to be easy to be able to, you cannot match it up because the deficit just keeps on increasing. So now effect of critical illness on different physiological functions, what happens is in a neurological patient, there is delirium, there's coma, there is the GCS scale, where it is definitely the fluids and the electrolytes are dearranged, especially the sodium, potassium, the fluids. You need to go to the rounds. You need to see what the intensivist or the consultant has written about the fluid restriction, whether the patient is in hypo or hypernatremia. As Dr. Praveen was mentioning, diabetes insipidus, where there would be so much of output. So you need to know that whether the patient is in hypo or hyper, depending on the fluid, which the target volume is set by the intensivist and the consultant. How are you going to design your nutrition care plan is very, very important, as volume-based feeding protocols is the norm, the international standards that is being accepted in all ICUs, irrespective of which specialty. So volume-based feeding protocols has been to have very good success in trying to improve the nutritional status of the patients. So in GI, especially when you come to neurocritical care, there is gastroparesis. In the cardiac, there is myocardial injury, there is edema, pulmonary, there is ARDS, respiratory failure. You will not be able to wean them out of the ventilator faster if their nutrition is so severe malnutrition. So in renal, you could have an AKI because of different conditions, or because they would have had somewhere a nephrotoxic reaction to it. There would be oliguria. So immunological response would be there where there is suppressed cell-mediated immunity also. Now, in a neuro ICU, what we need to make sure is the patient is already in a starvation mode already most of the time. So when you start a neuro ICU, pre-existing starvation is very common in some patients, which may decrease the result of electrolyte abnormalities will be common. So what you need to keep in mind is to prevent the refeeding syndrome must be kept in mind before initiating nutrition support in the neuro ICU, because they are so catabolic. And if you start at the 100% of nutrition, so if you think that the patient needs about 25 to 30 calories per kilogram per day, and if you're going to start at 80 to 100%, that is not going to work, because they might go into refeeding syndrome in the neuro ICU because there is pre-existing starvation in many patients in the neurocritical care. Now, high risk of patients which will go into refeeding syndrome are alcoholics, oncology patients. So it can be brain cancer if it is a neuro. It can be post-operative patients where they would come from a neurosurgery after a traumatic brain injury. They would go undergo surgery in an emergency where they would have gone into an RTA or a road traffic accident. Elderly patients, which is very common in neuro. So you need to make sure that they will always have polypharmacy because they would be diabetes, hypertensive, hypothyroid, so many comorbid conditions. They will have, you remember the thin fat Indian, which is told in many forums where muscle of an Indian population is already low. We are not as well built as the West. So the thin fat Indian, where we have central obesity, where sarcopenic obesity, all the more we need to start in a low rate. And the ESPEN and the ASPEN guidelines always says that you start with a very low rate. You can even take up to 5 to 7 days to reach the target volume, but do start so to prevent the translocation of bacteria so that there is better tolerance, and you need to start early enteral nutrition if the patient is hemodynamically stable within 24 to 48 hours in a neurocritical care. So other risk of refeeding syndrome, extreme, where there is obesity and also the BMI is less than 18.5, poor intake for greater than 5 days. So whenever the patient also comes, when you talk to the attender talking about if there is any intolerance or their weight history or their intake history the past 2-3 days, they would always say they've not eaten for 2-3 days, my spouse or my kid or the teenager who's gone in a bike and got into an accident. So they would be saying there would be poor intake, or it could be a dementia and Alzheimer's patients who cannot communicate. They will even forget they have eaten, or because of tremors, they will not like to ask for assistance and they eat very poorly. So all this need to be taken into consideration. Malnourished patients also are very, very at risk for refeeding syndrome. Now, barriers in providing nutrition, there are many, like in different ICUs, whether it's a surgical ICU, a liver ICU, thing with a neuro ICU also. Now, we all know that the GRV is not at all taken into consideration. You are not, the recent guidelines, ESPEN and ASPEN says that you don't need to keep on measuring the GRV, the gastric residual volume. Till up to 500 ml, it is okay. Only when you cross that 500 ml, you need to do it. Then also you don't need to stop the feeding. You can go into post-pyloric feeding. or you can use prokinetics, which will help the gastric motility. So now let's come to our forte, that is malnutrition screening tools in the ICU. Most of us are NABH accredited hospitals where we work. So you know that you need to have a validated screening tool, and one of the quality indicators might be to provide screening to assess the patient whether he is at risk within 24 hours of admission, whether in the ward or in the ICU. SGA, which is the subjective global assessment, is very commonly used in India, both in wards and in ICU. MUST tools also is very effective, the malnutrition universal screening tool. NRS 2002, it is very normally used in ICU. The mini nutritional assessment can be used in old age homes and other settings for geriatric population, and Nutrix score is also used in neuro ICUs. Now, what it is now you know that the SGA will have weight change 2 weeks up to 6 months. You also talk about change in the diet intake, the amount, the quantity, the type of food. They will be saying that he's not at all eating, he only has porridges, he's only taking juices, he's averse to solid food. So those things are captured in SGA. GI symptoms, maybe they would be constipated for days, and or they would have maybe intolerance, or their gastric motility would be very bad, gastroparesis, which is very common in type 2 also, where their HbA1c levels would be very high. Then in neuro, we always look at change in functional capacity, where the elderly population or where there is a long-term chronic neurological condition where there is functional capacity would be impaired. So that needs to be taken into consideration. These are some of the parameters that we assess when we are using SGA. We also look at clinical data, and we also look at subcutaneous fat, muscle wasting, edema, nutritional focus, physical examination at certain points where you can see that there are a lot of subcutaneous fat that is there, even around the eyes, the orbital area. Then you could see muscle wasting in the calf muscles and also in the upper hand. And definitely you have to look at pitting edema. Is there any other things that is causing this problem? MUST tool also, unplanned weight loss, 3 to 6 months is taken into consideration. In nutritional risk screening, which is 2002, where decreased dietary intake is also asked in the past week. We look at acute weight loss, unintentional weight loss for 3 to 6 months. In a mini nutrition assessment, we talk about food intake, whether there is severe illness. In the ICU, we look at weight loss, food intake, whether they have any other chronic issue that has been going on. So this is some of the parameters we look at when we use a certain screening tool. All these are validated screening tools. It is up to the dietitian and the nutrition support team, more so with the clinical dietitian, to see what is more suitable in their ICUs. Now, consequences of inappropriate feeding is very important in patients in neuro ICU, because they are very much prone to swallowing difficulties. They are prone to long-term placement of EN tubes, and also dysphagia is very common. So what we need to do is, what are the causes of this malnutrition? If the consequences of underfeeding has to be taken into consideration. This because worsening of outcomes with increased energy deficiency. So there is a negative nitrogen balance that keeps getting carried over, and we are unable to meet it over a period of time. So even if it is for 3 days, it just keeps adding up, and you are never able to match it, because of we cannot just feed them in 1 day and then try to say that we can go up to 3,000 calories in a day, which is just not possible. Now, malnutrition is associated with loss of lean body mass, poor wound healing, impaired immune function. So as I already told you, in the consequences of underfeeding in neuro ICU, pre-existing starvation is common. So which will have electrolyte imbalances. There would be organ dysfunction. So all these to be kept in mind whether you're going to make sure when you're going to start the appropriate feeding and you don't underfeed or overfeed the particular patient. So what happens is, as low as 14 calories, if you keep adding, there are some studies which says that identifying by the malnutrition, by the nutrition support team, by the clinical dietitian is very important. Some studies say that underfeeding even as low as 14 plus or minus 5 kilocalories per kilogram per day, there is a cumulative energy deficit of about just 117, that's what you might think, plus or minus 53 kilocalories per kilogram per day. For the first 7 days, this negative energy balance was associated with increased infectious complication. So the patient getting infection, hospital-acquired infection, keeps more prone, because even a calorie deficit of about 117 plus 53 or minus 53, what happens is these patients are more prone to infectious complication. More so with this, the same authors, they studied that older age, which is very common in the neuro ICU, so the geriatric population, the lower caloric intake, the negative nitrogen balance, these are good predictors of time required to deliver the first feeding is very important. And these patients which I listed out has a hospital acquired infection, they are more prone to getting this. So the new emerging strategies of this nutritional therapy in the neuro ICU emphasizes on identifying patients already malnourished or at risk of developing malnutrition. So you need to have setting a daily caloric goal for them. The ESPEN says start even as low as 15 to 20 calories, but try to go and try to reach the target up to, you can take up to 5 days, but make sure that you try to go in a phased manner so that you don't go into refeeding for these patients. Now, macro and micro, as I already told you, energy, protein, but continuous gravity back feeding is the international standard in all ICUs, more so in neuro cases, because they would be having a lot of hyperglycemia and the electrolyte disturbances are very high. So the energy, the protein, the fluid, the electrolytes, the minerals, micronutrients, the fiber, every single thing has to be taken into consideration. As you all know, constipation is a very, very common problem in the neuro ICU because of the gut motility. So the patient stage in the disease, the gastrointestinal intolerance. So when the patient is having spurious diarrhea, then the sister calls you and say, ma'am, you started the feed, continuous feed. That is why the patient has gone into, you just say, no, it's not because of my feed. Maybe we'll just try to address the volume, maybe request the consultant or the intensivist to start prokinetics. You can be a part of the team because the doctors and the consultants, the intensivists realize how important nutrition is. Aggressive, early, timely, phased manner nutrition delivery in the ICU is important to wean them off the ventilator, decrease the time in the ICU, and also overall decrease the length of stay in the hospital. So likely duration of nutritional support. So you know that these many patients have dysphagia, their GCS is low, so they will be in a coma, they will be in a delirious state, they will not be able to take orally, many of them are in enteral nutrition. So if the patient is on Riles tube, you know that if it is more than 3 weeks, a PEG is recommended by the doctor and also by the nutritionist. So the risk of developing refeeding syndrome has to be taken into consideration. Serum glucose fluctuations is a major part in many ICUs, more so in neuro ICUs. So we need to take all this into consideration. Have a nutrition care plan every day in the rounds. You need to see the electrolytes that is being recorded, documented in the ICU case sheet. You need to record in your nutritional care plan. You need to see whether soda mint is going. You need to see whether propofol has been started. So you need to take what is the IV, the dextrose. So the calorie from that Propofol solution, which is 1.1 kilocalorie per ml, if it is started, that also needs to be taken into consideration. If what are the NaCl that is going, the 5%, the dextrose, or is it pringolactate? So many things has to, you also need to know as a clinical dietitian, what are the IV that is going on, what is the target volume that is being given to you for the enteral feeds. So you know that the IV, this much volume is going, and what is the volume that you need to calculate and write in the volume-based feeding in your nutrition care plan, in your daily ICU notes, so that you know that the sister, the person who's taking care, the nursing staff knows that they know how to do the volume-based feeding correctly. So the communication has to be very clear. The chart has to say the previous day's intake output, whether the patient is in negative balance, positive balance, bowel opened, is he constipated for 2-3 days, can you increase the fiber in the feeds. All these need to be taken into consideration. Blood sugar control, how tight do you want to be? How tight is tight enough? Now let's look at the NICE sugar trial. So there is neurocritical care patients, traumatic brain injury, spinal cord injury, there would be stroke, infection, encephalopathy. So what we need to see, the NICE sugar trial says normoglycemia in the intensive care evaluation, and they've also had a surviving surviving the using the glucose algorithm. What they have found out is no mortality benefit of intense glucose control is not necessary, because if you have very tight control of the glucose, the hypoglycemic episodes were more higher. So they wanted to say that tight sugar control only improved in, they don't show only in neurological outcome, only in ischemic stroke, not in ischemic stroke patients. So improved only in TBI, intracranial hemorrhage, and SAH. Other things there is only when they wanted in a certain range. So you don't need to have it in a very tight control. So you need to make sure that the GRBS, which is being checked every few hours, what is the thing? Can you do something about the glucose? Is it, can you change the formula? But though we use only polymeric formula in all these patients, that is the norm, that is the recommendation. But if there is a hypokalemia or a hyperkalemia, is there which anything that you can use to flush the tubes? Maybe instead of water, you can use tender coconut water to do it through the NG feed. So the potassium, which is low, can be increased. As you all know, the tender coconut water is rich in potassium. So small things that you do will also help. So you also, if the patient is in hyponatremia, you should also know that how much is the salt that is given through NaCl, the soda mint, and what is the gram of salt that you are going to recommend in those feeds. Is it alternate feeds? Is it in the volume-based feeding protocols? All these need to be taken into consideration. Complications with feeding, mechanical in enteral, there is tube-related complications. Patients do pull it out. There is obstruction, there would be a clot, they wouldn't have flushed it properly. And GI complications, they would go into diarrhea, which is common, or constipation, metabolic derangements. If the gut is not working, if there is an obstruction, then only the parenteral is started, as you all know. So even if in complications with parenteral feeding, there are mechanical, the site of infection where you do a central line, or a peripheral parenteral nutrition, supplemental parenteral nutrition, where what is the osmolality you're giving, whether it is a central line or a peripheral line. You need to make sure that the right osmolality formula is selected so it goes in the correct line. Infections are very common, and metabolic derangements, as you all know, the electrolytes need to be checked, and which is very common. Now in neuro ICU, in TBI, in a traumatic brain injury, you know that many young youth, or irrespective of gender, they come because of traumatic brain injury, in a road traffic accident, they don't wear helmet, in a bike, in a car, whatever it is, very common that is seen. The hypermetabolic response is so high that it is matches to burns, which is 20 to 40% of the body surface area, and they go into septic shock. So by the time they go into surgery, if necessary, and they come out of it, within 1 or 2 days, you can see that there is so much high of subcutaneous fat, the lean body mass. They're so much into excessive catabolism. So the protein catabolism is so high that they break down so fast. There is negative nitrogen imbalance, hyperglycemia is common, and all this is taken into consideration. In a stroke, what they found out in the food trial, which is basically whether they are taking feed or ordinary food trial, that is what stands for the acronym FOOD. Now, what they found out is in Dennis et al., there was a study which says that stroke patients with dysphagia, early feeding or no feeding within 7 days, or if there is a NG feed versus PEG feeds. So there is a multi-center study that was done, which says that early EN feedings has benefit. PEG feeding is not superior to NG feeds. Only if it is in a very prolonged, you need NG, then only PEG is done by the surgeons. So IAPEN says that in 4 weeks, PEG should be initiated. If the patient needs enteral feeds for more than 4 weeks, then only the PEG is initiated. That is the norm that is being told by the IAPEN. And so what happens is glucose control. Now, you need to understand that in a stroke patient, dysphagia is very common, and rehabilitation in all these neuro patients, because of the severe catabolism, we are not talking about just only ICU, then the ward, and they are fine. There is a lot of patients which need a prolonged rehabilitation phase, which needs, because of intense physiotherapy, occupational therapy, speech therapy, and the speech language pathologist or the swallow therapist is going to initiate feeding. And you as a clinical dietitian, you need to know the texture modified diet that has to be given. So rehabilitation plays a very important role, and the clinical dietitian or the neuronutritionist is very important to ensure that adequate energy, protein, and the good fats are given. Both micro and macronutrients are in adequate amounts and the right amounts so that it is given. In SAH, subarachnoid hemorrhage, energy requirements are so high in the early post-bleed stage. So what happens is the cerebral glucose consumption increases. There is increase in hypoglycemia, enteral nutrition, optimal nutritional support is very important in such cases, and enteral nutrition and insulin administration. So you know, many of you are diabetes educators also, so you know the type of insulin, the short acting, the mediate acting, the long acting, and what are the things which go, so you know how the hypoglycemia takes place. So I think in SAH, where the right nutrition, optimal nutrition support is very, very important. Excuse me. Spinal cord injury. Since it is a severe trauma, the energy expenditure increases markedly after injury. There is muscle paralysis, there is steroid administration. So what happens is the negative nitrogen balance peaks at 3 weeks. It lasts up to 7 weeks. So you can imagine the amount of muscle wastage, the muscle breakdown, the protein catabolism that is going to happen in this type of patients. So the 2/3 of the spinal cord injury patients are malnourished, undernourished, or obese. So there will be malnutrition in 2 extremes. So the rehab center, where the rehabilitation, where the nutrition plays a very important role. Well-planned nutritional therapy is very necessary for these spinal cord injury patients. So you need to assess your patients very correctly and need to give the right nutrition at the right time. Guillain-Barré syndrome. So as I told you, these are neuro cases where they need hospitalization. They would go into mechanical ventilation. They would be eating really well, suddenly 1 or 2 days, and you should know that within the 3rd day, they will suddenly start having dysphagia because of the muscle paralysis, the affected nerve. So what happens is you need to know that, yes, there is a high chance of them going into dysphagia. So you need to monitor their oral intake. You need to be very alert in these type of patients. So Infections are common. They might be in mechanical ventilation. Enteral nutrition would be started. But if they are taking orally and within the third day, suddenly they might have started dysphagia. So you can just not start on a normal diet and assume that they would be fine. You need to be alert and you need to anticipate some dysphagia also in the Guillain-Barré, and you need to make sure that these are young patients which get into GB syndrome. You need to prevent muscle wasting. Long-term rehabilitation is in the cards. So you need to make sure they have the right nutrition even in the rehabilitation phase. Teamwork is more so in the neurocritical care, neurointensivist, the consultant, the endocrinologist because of the fluctuating sugars, clinical dietitian or the neuronutritionist, and definitely the nursing support team, the physiotherapist, occupational therapist, the respiratory therapist, because they would be giving respiratory therapy. And you need to have a very good understanding with the physiotherapist, because when there is an enteral feed, whether it's bolus in the ward or is it a continuous feed, you need to answer, because mobility is very important. They mobilize the patient even in ICU. So they would transfer them to the chair or even to just prop them up. Mobility is given so much importance because there are a lot of papers out there which says that you need to mobilize the patient if they are stable. So you need to understand, communicate with your nutrition support team, the nurses, the physiotherapists, to say nutrition is very, very important. See, this is the time the feeding is going to go. This is the time the physiotherapist is going to. So if it is a continuous feeding, there is no need to stop it at all. If it is a bolus feeding in the wards, you need to have a very good understanding with the physiotherapist, because both physiotherapy and keeping in mind these are rehabilitative and long-term patients which needs physiotherapy for long-term, and definitely they need nutrition. So you being a part of the team where you understand the importance of physiotherapy and they understand the importance of nutrition. So you have a very good smooth work, so the patient has the better and the best outcomes, which is what as team we work for. So nutrition should be given very much importance. In conclusion, early screening, appropriate timely intervention in high-risk patients, multidisciplinary team approach, nutritional support teams and the protocols, feeding protocols in the ICU tailored to your ICUs. Volume-based feeding should be given importance. Avoiding negative nitrogen balance and long-term nutrition support should be taken into consideration. So we have the right start so that the outcomes are the best. These are my references. And you should always understand, when you work as a single team, see, you have the best outcomes. Thank you for patient listening. And any questions? Over to you, Doctor. Thank you so much.
Thank you so much, madam, for such an elaborate talk and sharing your thoughts. And especially, I was actually very keen to look at the scales which are used for evaluation purposes, because that's somewhere I need to design the trials and I continue to struggle. So I've got like a list of one, and I know from which what I can get, So that was very important for me, and that's a learning from me from here. And of course, elaborating on the consequences of both the under and the overfeeding is something which we need to be looking at. I'm sure we have about 60 people with us on the webinar, and I look forward to see if they have any questions. I can click on the chat box. You're free to ask. There is a question. Can you throw some light, I believe, on the nutritional leads in depression, anxiety, and anorexia? Are there any specific needs?
Yes.
And the role of omega-3 fatty acids in traumatic brain injury. So that's next one. But first, we're looking at depression, anxiety, and anorexia.
Okay. So there are a lot of papers which says the food and mood is very much related, and in depression and anxiety, there is nutritional psychiatry is a very new topic and an emerging field. We also covered it in our IAPEN India conference in AIMS, which we did it 2 months ago. And there are a lot of antioxidants which can be given, and there are papers which says the length of depression and the degree, the severity of depression also comes down based on the right food. So the antioxidants, the Mediterranean diet, and also all these diets. So it is very easy. For example, last week when I got one of the cases through reference about Mediterranean diet, that patient was very clear because it was late teens. She was very clear that she don't want to eat any plant and fruits, plant-based thing, because she doesn't like fruits, and vegetable consumption was very low. So it's very easy to say theoretically a Mediterranean diet. We need to motivate them, assess their food daily intake, and then see. So depression and anxiety, yes, there are a lot of papers out there which says that the more plant-based diet, the more colorful you eat, rich in antioxidants, yes, does bring down the depression and the anxiety levels.
It's like when you talked about this and enriching the diet with the colors and, the antioxidants and other things. I was taken back to my college days when they used to emphasize that enrichment, the environmental enrichment, is as much a part of the therapy as probably antidepressant is, and with SNRIs and all kinds of things that we have today, with the burning and constipation and per se, is there a particular anything more than the antioxidants and other things to do? We'll be looking at maybe, and with the patient suffering from depression, there is a huge amount of psychomotor retardation there, unlike anxiety, where the patient may have or will have, certainly will have psychomotor agitation there. So is there somewhere that there need to be a more specific diet for those individuals experiencing depression, and vice versa the patients who are more anxious rather than depressed?
Definitely.
Yeah. So about somebody I was checking, they are asking about the fiber in the diet.
Yeah.
Yes, I'm missing because the questions are coming thick and fast, and my screen keeps on moving. So, what about
So
the role of
regarding
fatty acids? They would like to
Dr.
also.
Harsh, maybe regarding anorexia and bulimia, Dr.
Yeah.
Praveen, can just
Yes.
put some light first, and then
Yeah,
I'll
I'm
talk
waiting to
about
hear
fiber.
from you. Yes. Sir, your thoughts?
See, as we say, the poor nutrition not only brings on other disease aspects within bulimia and anorexia, but it can also augment or accentuate the ill effects of the said disease. Anorexic individuals, not only do they have certain specific food fads in their mind, they are convinced that those food fads are the in thing, and they will not believe, or in fact, most of their beliefs, they will not take it away just because we tell them to. So these patients will have to be dealt with very, very delicately. And not only will medications help, but more importantly, as you said, counseling the parents and the patient, probably either separately or together, will help. And devising specific diet plans, but more than devising, making sure those are actually administered and they're actually taken to fruition are more important. So this has to be done in conjunction, I think, with their religious practices, their food practices at home, and all these will have to be probably given importance. As far as bulimia is concerned, most of these patients are also malnutrition, in the sense that they tend to say go for repeated vomiting or retching after eating their heart full. So they tend to have, say, poor dentition. They tend to have reflux esophagitis. They tend to have severe acidity. They tend to have a lot of these mineral deficiencies, and then eating disorders. So certain food fads which are easily available for them, like say junk food, or food which actually initially pleases them, like say ice cream or chips. So those difficult to keep them away from them if they have easy access. So here, not only the patient, the doctor, and the dietitian are a triangle, but the parent or the guardian becomes a very, very important part of the golden quadrilateral. So I think importance to medications, counseling, diet counseling, all these will have to be given. We also have to understand that in the initial part, they may not really understand, but as the therapy gains momentum and then they start improving, so they are more receptive to these ideas, and they will start believing, and then they'll start adjusting to the new methods available.
Well, that's very succinctly put, sir. There's so many questions. I have to keep on moving my screen, you know. One of the audience is keen to understand from you the role of omega-3 fatty acids in TBI.
Yeah, we do give role of omega-3 in TBI, but the thing is, it's mostly the polymeric formula. We don't give separate supplements, though glutamine is recommended in IAPEN papers where it says, yes, in traumatic brain injury and burns, glutamine is there, omega-3, yes, fatty acid supplementation, but most of the polymeric formulas also have it. So maybe in the recovery phase, yes, we can give it, but it is, yes, warranted in traumatic brain injury.
Another question which is there, ma'am, which seems an audience wants to know, when do you initiate oral feeding in tube feed patients in the neuro wards?
That is definitely, as Dr. Praveen pointed out, it is with the FES, the fees, whatever the ENT and the speech language pathologist. The ENT team would first do a endoscopic evaluation of the swallowing. Then only they will make sure that it is fine. And then the dietitian comes in the picture with the texture modified diet. Dr. Praveen, would you like to elaborate, please?
Yes, most of our patients, neuro patients, especially if you expect a short-term recovery, like say post-intubation, or if the patient has undergone surgery and we have really not damaged any of the neural structures, we expect them to improve immediately. And then maybe after about 24 or 48 hours of fasting, we do initiate their feeding, say, with mainly semi-solid diet first. But before this, as we said, if we expect injury to any of the neural structures, the pathways that I already mentioned in any of the stages of deglutition, we definitely get our ENT colleague to do a video laryngoscopy as swallowing assessment. Once the assessment is done through both objective and subjective measures, where we give them a small bolus of water to drink, as I showed in the video, we can clearly see aspiration of the liquid through the epiglottis into the food pipe itself, into the windpipe itself. That's when we avoid feeding them through the mouth. But if the patient is fully conscious and if the swallowing assessment is good, or if the patient after a certain amount of time is being made to, is trained to swallow, say, soft diet or semi-solid diet, only then will the liquids be given. So I have to emphasize here, in fact, in the wards, most of the nurses, we have had repeated problems where they try to give water first to our neuro patients. We tell them that these are not GI patients where you start with liquid diet and then go on to give them solid diet. Here, these are neurologically obtended patients where we first give them soft morsels of, say, we tell them either kesari bath, or upma, or mashed bananas, and these things are kept in the mouth first. And if the patient is conscious and if the swallowing is good, they don't choke, they swallow by themselves through the posterior pharynx. If not, they just spit it out. Then it becomes easier and then it becomes less risky, and then the aspiration is avoided. Vis-a-vis giving water first, where uncontrollably the water goes into the trachea, causing the patient to choke or aspirate. So this is one of the important things that I'd like to say. Swallowing assessment, as Dr. Srimati put it, is a must in a neuro setup, and we routinely use our ENT colleagues' help to assess swallowing function. Sometimes we may have to do it repeatedly in the OPD setting on follow-up, but for that we do require a cooperative patient who will be able to sit upright, and our ENT colleague is able to pass an endoscope through the, or a fluoroscope through the nose, and then assess the swallowing function.
Thank you so much, sir. Madam, you have something to say? I see you were indicating you wanted to say something further on that. Okay. We have a question coming to you. It says that calories recommended in head injury with polytrauma, as per IAPEN, is 12 to 25 kilocalories. So they want to know what's your take on that, or shall we go with more than, because what they are suggesting is 25 to 30 kilocalories. A higher requirement is what they are suggesting. Your take on that?
Yeah, so IAPEN very clearly says the guidelines is start because start in a very phased manner. So start with a 15 to 20 kilocalories, and then maybe up to 5 days you can take your time to reach the target. But yes, definitely they need about 25 to 30 kilocalories per kilogram body weight. That is the target you need to achieve, but you can start as low as 15 to 20 And then by the third day, you can go up to 25 to 30 kilocals and not just start as 100%, because they would be having post-surgery, they would have been taken for craniotomy and other things. So you need to not just start at 100% because of the refeeding risk.
You said third by 3 days to achieve that? Or you
It
mentioned
says
5?
up to 5 days. I spent
Yes, that's what was I collected from your
says
thought.
that
Yeah,
you can take up to 5 days, whether it's
to build up.
and the calories you need to take up to 5 days, and it is okay to take up to 5 days to reach that calorie goal or the protein goal.
A question which comes, which was about the role of choline. I would like to ask you and Dr. Praveen as well, the role of choline and inositol supplementations in brain health. This has come twice or thrice, this question. Any thoughts on that?
Choline, as we all know, is a building block of neural membranes. Not only is it available in a readily marketable pharmaceutical form where we give as choline supplement injections and tablets, what they have actually detected on studies is that the functional outcome at the end of 6 months in severe traumatic brain injury or in strokes are much better in those patients who have been given these choline supplements. Typically, it's given for about a month at least. And some papers say it has been given for at least 2 months. Initially, when the patient is, say, nil-oral or not on NG feeds, we can give them even through injectable means, and it can be readily converted to orally available formulations. There are a lot of these combinations available with choline with pyracetam also for brain health. Yes. So inositol, I don't have much knowledge about, but choline, yes.
Okay. So I hope that answers your question, the audience who is asked. Yes, that doctor has indicated, Dr. Praveen, that choline certainly is helpful, and there is substantial body of evidence justifying the use also. One more question which has come, sir, is what do we initiate? When do we initiate actually? I think it is to the madam that when do we initiate oral feeding in tube-fed patients, neuro patients? How early probably that they want to do? In the tube-fed patients, when do we switch over? Are there any pointers to that? Are there any indicators to that?
We've already told that unless a swallowing assessment is done, we cannot start because risk of aspiration is high. There is a oropharyngeal dysphagia. There are other dysphagias that is there. It can be in a Parkinson patient. It can be in an ALS. It can be a Guillain-Barré where after 2 days, suddenly they'll go into dysphagia. So there are so many things. It is not like very set. It is not a one size fits all. It depends upon the swallowing assessment, as doctor pointed out. It can be with starting thing, ENT team, the swallowing therapist, the nutritionist, everybody is in picture, and we need to get the proper assessment done before we initiate. And there can be months and many times till PEG they would be on a thing where they will not be taking orally, and they would be within, doctor pointed out, 24 hours, 48 hours they might do. So it depends upon where the brain injury, what condition, the chronic condition which is there, the patient, and then the swallowing assessment is done, because we don't want the patient to go into aspiration and land up in the ICU.
So there is no rule of thumb here, which is very clear, and it varies from the patient to patient, situation to situation, which it's a multidisciplinary decision that which needs to be looked into by everybody as a team, and it's not just one single individual who's been looking at it. I think I've come towards the end of the questions. If there is anything else, ladies and gentlemen, please let me know. Otherwise, I'll thanking Dr. Praveen KS for making us understand the various aspects of the requirement, as well as Dr. Srimati for taking us through the nutrition management and practical approach in neurocritical care. If there is any other question, please do get on the chat box and do let me know. I think we have answered, and especially Dr. Srimati, we were very elaborate talk, and as I mentioned early on that for me, the scales were very important because to devise a trial and to understand, how to use them and what to do. So thank you so much, Dr. Praveen. for being a part of this program, and also Dr. Srimati for sharing your views and experience on this. With this, I sign off. I thank you again on the behalf of Pulse Pharmaceuticals and Pulse NutriSciences for making it possible for us to share, the learnings and your experience with the broad spectrum of audience. Thank you so very much.